And just let me know, can you all see the screen? Can you see the presentation yet?
Yeah. Yes.
Perfect, good.
Yes.
Lovely. So postmenopausal bleeding. So this is going to cover the learning objectives from SIP 11. That's to do with managing non-acute gynae problems. So identifying causes of postmenopausal bleeding, taking a focus history, appropriate examination, ordering appropriate investigations. It's always good to know the risk factors and protective factors for endometrial cancer, because that will form the basis of your history taking. And then we're going to touch very briefly upon staging, treatment and recurrence. But that might just be a little bit more than what you need for ST1 and 2 and for the part 1 exam. So we'll start off with a case study, and that's how I've done it. There are some case studies, and then there are opportunities to discuss things as well. Obviously, do stop and ask me any questions at any point if you want to. So we're starting off with a 58-year-old. Let's say she's never been pregnant, who's presented with postmenopausal bleeding. She's got a history of being a type 2 diabetic and hypertension and a BMI 42. What else would you want to ask in her history?
Is this the first episode?
Sure. Does it matter if
when
it's a first episode or second episode, or it keeps happening? Does it matter?
No.
No, because any episode of postmenopausal bleeding, we need to obviously look into it. I mean, if she's had it before, then it just maybe helps her to understand the process a bit better, doesn't it? So she'll know what a hysteroscopy is and that she needs to have biopsy and things. But generally speaking, every episode we do need to look into it. But fine, yes. And what else would you want to ask?
When was her last period?
Absolutely. So when was her last period? We'll take both of those points, because you know, sometimes we will get sent women who are apparently postmenopausal, but actually they've been bleeding irregularly. So obviously, to be postmenopausal, you shouldn't have had a period for at least a year. Absolutely. And has she been on HRT? That's very important. Why does it matter about HRT?
If they've recently changed HRT, then that can cause some erratic bleeding.
It can indeed. So it's important to know. What else about HRT?
Unopposed HRT above 60 years old can predispose to cancer too.
Absolutely. I don't think it matters if they're over 60 or not, but just unopposed estrogen. Yes. So it's important to know what type of estrogen that they're taking. And obviously, if they've got a uterus, they need to have that progesterogenic protection, don't they? Fine. Is there anything else we'd want to know about her?
Any surgeries?
History of cancers?
Yep. History of cancers. Any particular cancers?
Breast cancer, tamoxifen use.
Yeah, absolutely. Breast cancer, tamoxifen. Why does tamoxifen matter?
Increases the risk of endometrial cancer.
So it's anti-estrogenic on the breast, isn't it? But it's pro-estrogenic effects on the endometrium. So yes, it can increase your risk. Sorry, somebody else said yes, the different types of cancer. You know, someone might say, oh, my mum had endometrial cancer, and, you know, sometimes we might be a little bit dismissive, but there can be some genetic predispositions, can't there? So it is definitely important to ask for a family history. Don't forget smear history as well. Just, you know, don't forget your complete history taking, and yes, surgical history, because it might affect how you plan surgery for this patient. What are you going to do for this patient next then? So you've taken your history. I assume you'll examine her. Examination wise, what are you guys going? What will you do?
Manual examination, feel for any masses.
So always start with abdominal palpation. Can you feel anything obvious? Yep.
So you could try and do a Papel. Could you try and do a Papel biopsy?
Yes,
like
definitely.
Bleeding.
Yes. So just to finish off, in terms of examination, abdominal palpation, I know this sounds very basic, but it's surprising. Well, GPs are obviously not really seeing these patients and they're just referring them on. But it's just making sure you're doing complete assessment. So abdominal palpation, vaginal examination, bimanual, you know, looking for other causes that she might have bleeding, atrophy or anything on the cervix. And then yes, you want to do a Pipelle biopsy. Everywhere seems to do it slightly differently, and there is no real genuine consensus about what the best way is to investigate these women. But yes, you would want to sample the endometrium. Sometimes you could, when I was training, we used to nearly everyone just had a Pipelle biopsy in a general gynae clinic, but now it seems to be more of a trend that these women are referred to outpatient hysteroscopy where that's available, and they'll have a biopsy, or maybe they go on to have a GA hysteroscopy and a biopsy. But essentially, you want to do a biopsy. Anything else that you would want to do? So any other investigation?
Ultrasound.
Tumor markers.
Let's start with tumour markers. Why would we want to do them, and if you want to, which tumour markers are you going to do? Stunned silence. So with endometrial cancer, the tumour markers are not helpful. There is nothing specific. Even then, there aren't very many tumour markers, are there, when it comes to gynae cancers? Even CA125 is very non-specific, isn't it? So no, tumour markers wouldn't have a role, but we definitely want to do an ultrasound. Transvaginal scan is definitely better. We'll talk about it a little bit more later and what the cutoff is, because you may not need to do an endometrial biopsy in everybody. Okay, so presentation-wise, so the signs and symptoms that they'll have, we've obviously mentioned they may have some bleeding, and we know that this could be anything from a little bit of spotting and wiping to a full-blown period-like bleed. What other symptoms might they present with?
Pain, abdominal pain.
They can do, yes, pain, discomfort.
Pressure symptoms if the cancer had really progressed.
Yes, but again, it goes. Pain, pressure would probably go hand in hand. I'd probably expect, maybe something else. So what if
Dyspareunia?
Why would they have dyspareunia? I don't think that would be top of your list. I'm not sure really how that would fit. But don't forget simple symptoms such as vaginal discharge. That could be something as benign as that. Excuse me. What if they're premenopausal? Because I know we're focusing on menopausal symptoms because I've mentioned postmenopausal bleeding, but if we're thinking endometrial cancer, it can obviously affect premenopausal women. What symptoms might they present with then?
Intermenstrual or postcoital bleeding.
Intermenstrual bleeding, yes. Postcoital, possibly. And also heavy periods, just heavy menstrual bleeding, yeah? So it's just something to think about, albeit uncommon, but it can be a presentation. So 90% of women with postmenopausal bleeding, 90% of these women will have a benign underlying cause, and we'll look at alternative causes in a minute. So that means that only a very small proportion of women, and it's actually slightly less than 10%, but this is just to help you remember in general, because it helps to speak to these women and say most of the time actually there's either we find nothing or it's a completely benign cause, and it's the chance of cancer is still low. So they may have discharge, alpyometry, I forgot to mention that, intermenstrual postmenopausal bleeding in premenopausal women, and later on, yes, pain, distension, any pressure symptoms as well. So these are, oh, sorry, I should have asked you this, but these are the other causes of postmenopausal bleeding to think about. So you've obviously got all the malignant things, so all the different types of cancers, pre-malignant hyperplasia as well. But the commonest thing that we will find, either there is no cause identified, which is all the way at the bottom, or they may have polyps or atrophy. And somebody's already mentioned unscheduled bleeding in women using HRT. Anticoagulant therapy, I have to say we don't come across that very often, but those are all generally the different causes to think about. Now, sorry. What does NICE say? Did anybody have a quick look at the screen? What does the NICE say? NICE says, so we obviously know anyone with any postmenopausal bleeding, so if they've not had a period for 12 months, they need to be referred. How should they be referred?
2-week wait.
Absolutely. And that's important because sometimes when you're on call, you may get a GP calling you, or somebody calls from ED and saying that they've got this patient, or someone calls from the ward and she happens to have, they've noticed some bleeding. I mean, obviously, if they're an inpatient, that's slightly different. You'll probably arrange for her to have a scan and possibly a biopsy while she's an inpatient. But you will get, sometimes you'll get referrals. So it's important to know. And we get advice and guidance from GPs still, and they say, oh, this lady's had a bit of a bleed, and what would you like us to do? It's important that they have a 2-week wait referral. What about with premenopausal women? When do we need to think about sending them in to be investigated? So we said for intermenstrual bleeding or heavy menstrual bleeding.
If you've tried if you've tried things like the Mirena or like other therapies and they failed, then would you refer them in?
So not necessarily, because what's the commonest reason for heavy menstrual periods in a premenopausal woman? The commonest cause is there is no cause. It's just dysfunctional uterine bleeding, isn't it? So it's not to say you would send everybody in, because you might have a 23-year-old that's having all these persistent problems and things. So what I'm trying to get to in a very long-winded way is, do you know what the age cutoff is when these women definitely need to be seen?
Is it 45?
40?
45, yes. So anyone, so again, important to know, if you see someone in gynae clinic who's having these heavy periods, or it may or may not be responding, but regardless, anyone over the age of 45 should have a biopsy, because there can be a risk of hyperplasia. Rarely cancer, but hyperplasia is what you're thinking about. And so that's what NICE says. So these are so in the box, you can see the NICE referral guidance. So we've said 2-week wait. I mean, it specifies age over 55, but actually it should be anyone that's got post-menopausal bleeding, and if they've got unexplained discharge, or if they've got hematuria. Hematuria is a difficult one, but these women, at least you can exclude a gynecological cause, and then if there is nothing, send them to over to urology. But for premenopausal women, any heavy irregular bleeding, full history examination, and they should also be referred to have a biopsy done. So and I've already kind of said this, what are the chances of someone younger having cancer? It's less than 1% who women under the age of 50, 24%. So it's obviously the older you get, the higher the chances of cancer. Somebody mentioned the risk, HRT. So if someone's got persistent unscheduled bleeding for more than 6 months after starting HRT, have to be referred. So again, if you're referred a patient or GP calls for advice, they've just changed their HRT. 6 months seems like a long time, actually, but that's what NICE guidance is. Give it up to 6 months. If it's continuing, refer her in, and if it's settled, then if it settles in that time frame, then that's fine. Those with new onset postmenopausal bleeding should be referred if bleeding continues 6 weeks after stopping the HRT, because by then you would have expected any changes related to the HRT should have settled, and any bleeding should have settled as well. So some questions, true or false, specifically about endometrial cancer. What do we think? So it's the most commonest gynecological cancer in developed countries, true or false?
True.
It is, yes. 4th most commonest cancer in women in the UK?
True.
It is indeed. The incidence has been decreasing.
False.
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 Why do we think it's false?
Because obesity is increasing and
BMI.
high BMI drives estrogen, so it's likely to increase.
Absolutely. Actually, the rates have increased by about 1/4 in the last decade, by nearly 2/3 since the 1990s. So, as you say, in part because of the increasing BMI, but also an aging population. So people obviously living longer. And before, remember, we used to do a lot more hysterectomies for benign disease, and I'm sure there would have been lots of cases of hyperplasia, even early stage endometrial cancer, which happened to be removed. So yes, the rates have definitely been going up. And what about this? Approximately 1/3 of cases can be prevented.
True.
Anybody else? The answer is true. It struck me as quite a significant proportion, really, that a third of these cancers can be. And again, it's related to lifestyle, isn't it? So predominantly to do with diet, obesity, and diabetes, if I didn't say that. Okay, so etiology. So someone already said this already. What's the underlying etiology then for endometrial, for the endometrial cancers?
Unopposed estrogen.
Yes. So majority of them are, it's unopposed estrogen because it's unopposed by progesterone. So if they've got, I don't know, coil in, or if they're still premenopausal, they'll still have the progesterone in their system, but it's unopposed estrogenic effects that causes endometrial cell proliferation, obviously, and then it can cause hyperplasia and can lead on to malignancy as well. So I will cover a bit about hyperplasia later on. What are the risk factors? We've spoken about a lot of them already. So we mentioned obesity, didn't we? So we've said about obesity, aging population.
Early menopause.
Early menopause, early or late menopause? It's early something and late something.
Early menarche.
Late menopause.
Yes. So the way to think about it is the more uninterrupted cycles a woman has, the higher her chances of cancer. So if she's had an early menarche, so she's been young when she started her periods, late when she stopped her periods, if she's a nullip, so never been pregnant. So if you've never been pregnant, your risks of cancer with alongside other risk factors can be as high as 35 to 40%. And if you've had at least one child, your risk reduces by a third. And if you've had 2 or more children, it reduces by about 25% with each birth. I mean, I know we see lots of women who are multips who still get cancer, but it is definitely protective. So yes, any other risk factors? And I guess actually these relate to obesity anyway, but diabetes, there's an increased risk probably related to being obese. Polycystic ovarian syndrome, again, it probably all ties in with metabolic derangement and obesity as well. HRT, we've already said, so if it's estrogen only HRT, it increases your risk 2 to 3-fold, and obviously the risk increases the longer that you're using the HRT. And then we mentioned about genetics. Family history. Does anyone know of any specific syndromes or genetic problems that can cause or be associated with endometrial cancer?
Lynch syndrome.
Lynch syndrome, indeed, yes. So apparently they have a 40 to 60% lifetime risk of cancer. Do you know what's recommended for these patients? So normally it's recommended that they have an annual screen from as young as 35, and usually that involves a scan and a biopsy as well. And then also apparently lack of physical activity. Again, I guess this makes sense in hand with obesity. So you can reduce the risk by 5% per 1 hour a week of exercise. It's just something to bear in mind going forward, ladies. And protective factors. We've already mentioned having babies is protective, exercise is protective. Anything else that anyone can think of that can be protective?
Use of combined oral contraceptive.
Absolutely, yes. Do you know how long the effects might last for? So apparently, once you stop taking it, the effects may last for up to 5 years, and may even last for up to 20 years, according to some studies. And it can reduce your risk of endometrial cancer by about 25%. Anything else? Another couple of risk factors relating to lifestyle. What do we think about smoking? Smoking can be good for you in this situation. It has some anti-estrogenic effects, but also these women are generally leaner, so possibly it's got that anti-obesity effect as well. But apparently smoking and high intake of coffee can reduce your risk of developing endometrial cancer. These seem like small trivial things, but sometimes these might come up as true-false questions in exams and things. So there's a little bit more there, a busy slide, I know, but I've kind of gone through most of those. And in premenopausal women, the major risk factors are anovulatory cycles such as PCOS, obesity, and I've mentioned there already about Lynch syndrome as well. So I've already said this. There's no real evidence to say how we should approach postmenopausal bleeding or any suspected endometrial cancer, but generally speaking, these women will have a scan. What are we looking for in the scan?
Endometrial thickness greater than 4 millimeters.
Yes. What about in premenopausal women? Does it matter? So in premenopausal women, using endometrial thickness is obviously not very helpful, is it? Because it obviously depends where she is in her cycle. But I'm sure you've all seen scan reports where it says gynae referral is advised. There is no cutoff, so it's very much is she over 45? What are her symptoms? Yes, you can refer women who are younger than 45 as well, but it obviously just depends on their symptoms. So we use an endometrial cutoff of 4 millimeters or less, essentially meaning that the chances of cancer are extremely small. So if she has an endometrial thickness less than 4 millimeters, she's got more than 99% negative predictive value, and the chances of cancer is really low. It's about 0.6%. So again, that's very encouraging. You must make sure you still examine these women, make sure there's no other cause such as atrophy, there's nothing on the cervix, but providing it's all fine, you can reassure them that the chances of cancer are very low. Does everyone use 4 millimeters in their unit, or do they use any different cutoffs? Have you come across anything different elsewhere? No, I think most places do use 4 millimeters, but you might find in other places they may use 5 millimeters, and there is lots of different levels in the literature and things, but that's what we generally tend to use in most hospitals. So scan, we spoke about scan, so hopefully you can appreciate that on the left, that's a really nice thin endometrium. So you have, this is your uterus, it's an anteverted uterus, this is anterior, posterior, that's her left, her right, and you can see really nice, clear, thin endometrial lining. Whereas here on the right, again, it's an anteverted uterus, there's the bladder there, and hopefully you can appreciate that the endometrium is significantly thickened. Yeah. And then there's just a note here that a recent systematic review of women with postmenopausal bleeding found that they had a mean endometrial thickness of about 16.4 millimeters. So again, it's just something for you to know about, so you could reassure women, because sometimes you'll get women who have a slightly thickened endometrium, 5, 6, 7, 8 millimeters, and evidence shows that it's the ones, and I guess this makes sense, the ones who've got a significantly thickened endometrium are more likely to have something malignant. Biopsy, we spoke about this. Pipelle, everyone's familiar with a Pipelle?
Yeah.
Okay, so it's very easy to use, isn't it? A very easy, simple, quick. And there is no right or wrong. Do you do it when you see someone in clinic? Do you have to have it visualized, pop in a camera and have a look first? There is no right or wrong, but as I say, it seems as though we're doing more of the latter, so we're doing the hysteroscopy and then take a biopsy at that time. So obviously there is the risk of missing small localized cancers, but if you are able to take a good sample, it can have a sensitivity of 90 to 100% detection for endometrial cancer. So when it's used properly, you get a good sample. It does yield good results. And with insufficient samples, about 10 to 15% of cases do have some underlying pathology. So again, it's important to know, because when you do a biopsy on someone, if their endometrial thickness was 4.556 millimeters and you get an insufficient sample, actually you're going to be more reassured, as opposed to someone that's had a thickened endometrium 10, 12 millimeters and it comes back insufficient. For those patients, you need to carry on and do the next step. So if you haven't done hysteroscopy already, they must have hysteroscopy. If they've only had it as an outpatient, then she needs to have a GA hysteroscopy, because the chances are you've probably missed something. So hysteroscopy, not very much to say. Do most places have outpatient hysteroscopy now? I know Wexham does, Reading does. How about other places? Anyone from Stoke?
Yeah, Stoke does have outpatient hysteroscopy.
Okay, and Oxford?
Same for Oxford.
Oh, great. And Milton Keynes?
Yeah, we have it as well.
Oh, perfect. Good. Gosh, things have come along a long way. It's a really useful procedure. Obviously, generally well tolerated, and the risks are similar to having a GA hysteroscopy. Really, main thing is obviously make sure these patients take some pain relief before they come in. But like I say, it's generally well tolerated. It's quick. It's easy. Avoids the GA, and you can do small procedures as well, can't you? We're doing MyoSure now, and we've just started NovaSure as well, so it's got a lot of good scope with it. Anyway, so that's most of the things I wanted to say about postmenopausal bleeding. This is a slightly busy slide, but this is essentially what we've said already. You guys can, I'll share the slides and you can go through it and look at it later on if you want to. So, investigations. I think we've already said this, really, haven't we? Examination is usually normal. So you must have a good inspection. Make sure there are no other causes. Do a bimanual as well. What investigation? So we've mentioned doing a scan, doing a biopsy. Anything else? Any blood tests that we might want to do?
FBC to just look for like anemia.
Uh-huh.
Infection markers if you're thinking of endometritis or some other cause.
Sure. Okay. Here we go. Full blood count, glucose levels, liver, renal function. You may want to do a cystoscopy if you're worried about any other disease, any other organ involvement. Obviously, you'd want to do some staging investigations as well, if once it's confirmed. Sorry, I've just been distracted. Oh, unfortunately, Sarah Phillips pulled out of the net. Okay. Never mind. Right, here we go. Carry on. So, oh goodness, this is a very busy slide. This is too much at the moment, but what I wanted to show you was the 5-year survival. I mean, you'll need to know this, you know, for your part 2 exam and things, but we're looking at the 5-year survival essentially. So the take-home message is, if you're going to have a cancer, this is probably one of the better cancers to have because it presents early. Generally speaking, they do present early with bleeding, easy to treat, do hysterectomy, so, and they've got a good 5-year survival. And the chances of needing any adjuvant therapy less likely compared to ovarian cancer, cervical cancer and things. So that's what this slide is about essentially, but it's FIGO staging. There are 4 different stages. First stage is limited to the body of the uterus, and then it's further subdivided. Is it less than or more than 50% of myometrial invasion confined? Then it's going just beyond the uterus and the cervix, and then spreading a little bit more locally, and then spreading beyond the pelvis for stage 4. Treatment, I'll let you guys just read this a moment. Okay, so we know all patients should be referred to the MDT. Surgery is the mainstay of practice, mainstay of treatment, sorry, especially for early disease, TAHPSO. You can manage these patients laparoscopically, providing they are suitable for laparoscopic surgery and it doesn't affect their outcome at all. So that's good for patient recovery, obviously, isn't it? Before everyone just automatically had a laparotomy. Use of any additional therapy obviously depends on stage, grade, and histological subtype as well. So in terms of where does this cancer go, it can spread directly either through the tubes into the ovaries, into the peritoneal cavity, but usually it goes into the myometrium and then through to the serosa. Then it can spread through the lymphatics and then lastly hematogenous to liver and other places and things. So the earlier the stage, essentially, the lower the chance that it's spread anywhere else. So, any questions about endometrial cancer? It's all fairly straightforward, and obviously because it's one of the commonest cancers that we deal with, like I say, it's straightforward. You can't really go particularly wrong with it. So the next case study is of a 45-year-old who's got heavy periods and intermenstrual bleeding for a few months. GP has helpfully checked her hemoglobin and her thyroid function, which is all completely normal. She's got a past history of PCOS and she's obese. So there we go. Completely, she has all the risk factors. The GPs actually referred her because they were unable to fit the coil. So we've already said this. We've already said this to some extent. But what we're worried about with this patient, not the chances of her having cancer, but the chances of her having hyperplasia. So a systematic review found that women with abnormal uterine bleeding, the risk of cancer or hyperplasia, it's low. So it's about just under 1.5%. And intermenstrual bleeding is a better predictor than heavy menstrual bleeding. But I'm sure we'd all agree, even if we didn't know before, but having covered this earlier on, that anyone over the age of 45, irregular bleeding, heavy bleeding, they need to be referred. So GPs are trying to manage this patient absolutely fine, checking if she's anemic, making sure it's not because of underactive thyroid, wants to treat with heavy period with a coil, but hasn't obviously thought to do refer her for a biopsy. So this is the point where you'll say, aha, this is what you need, and we can fit a coil for you at the same time. Who knows anything about hyperplasia? What is it? Are there different types?
So it's like, I guess, a precancerous change, and you can have hyperplasia with atypia or without atypia.
Yep.
And with atypia, I think generally you would do a hysterectomy because of the risk of progression to endometrial cancer is quite high. Without atypia, you would insert a Mirena coil as first line, and they would need 2 biopsies 6 months apart after that, before stopping surveillance. Yes.
Yeah, no, perfect. That's great. So as you say, hyperplasia, so precancerous changes can be with or without atypia. Without atypia can be simple or complex. And the reason why we further differentiate is the women who've got hyperplasia without atypia, especially simple atypia, they're the ones that are most likely to regress spontaneously, and the risk of those changes progressing to malignancy is low, so it's less than 5% over 20 years. So actually, if you had somebody with simple hyperplasia without atypia, if they weren't particularly keen to have any treatment, that would be fine. You could just see them again, do another biopsy, for example, in 6 months' time. The ones with complex, you'd probably want to do something. So as we've said, maybe pop in a coil, do another biopsy in about 6 months' time, or they could have oral progestogens if they don't fancy having a coil. And then obviously the ones with atypical hyperplasia, they're more likely to progress to malignancy. Sometimes it may not be suitable, or they may not want to have surgery. So yes, the coils or oral progestogens definitely have a role, and you can just see the risks of them progressing to cancer fairly significant. There's a whole Green Top guideline which is dedicated to hyperplasia, so that's as much as I'm going to say. So if you do want to read more, then you could definitely find more information there. So next we've got a 65-year-old who's admitted under the surgeons for diverticulitis, and on her CT scan it's just commented that the endometrium appears to be a little bit thickened, and they've recommended an urgent gynae referral. So what would you want to know from this patient?
She has any symptoms, any postmenopausal bleeding, or?
Yes, absolutely. So you will come across this very frequently, especially now that everyone seems to have a CT scan for something or other. And you'll find an incidental finding of a thickened endometrium, and the question is, does it matter? So first question you'd want to know from the patient is, has she had any bleeding or not, any abnormal symptoms or any discharge? Take a full history, obviously, find out if she's been on HRT, what's her parity, any risk factors and things. But generally speaking, if it's a thickened endometrium, more than 4 millimeters, we still need to find out. We do need to look into it further, so you can't just ignore it. There is no general consensus as to what requires further investigation, but all these women should be seen if it's more than 4 millimeters, and whether or not you then do the full works for her. Everyone seems to do it slightly differently, is what this is saying. So a prospective study of around 81 asymptomatic women found that the risks of either cancer or atypical hyperplasia was small. So 4 out of 81 women, and all these women had an endometrial thickness of more than 10 millimeters. So again, you will want to see these women, but it just helps in how you counsel them what you may want to do. So if you have someone that's got a thickened endometrium of 8 millimeters, you get an insufficient sample. Like I said before, you might be a bit more reassured compared to someone whose endometrium is 16 millimeters and you haven't managed to get a good sample. So it's just good to have that 10 millimeters in your head, but it's not a hard and fast rule. So yes, you still need to see them, essentially. Okay, so just a few questions just to wrap up, see how much you're all listening, really. Any questions so far?
Ms. Chairman, I was just wondering, if we were referred, for example, this case as kind of OG2, gynae red, would we advise them to have an ultrasound as well?
Yes.
Yeah.
Yes. Oh, yes. Sorry, I should have said that. Yeah, absolutely. Because an ultrasound's definitely more better at looking at gynae bits than a CT will be, and it can be more accurate as well. So if on the ultrasound, obviously the endometrial thickness is 4 millimeters or less, that's fine. We're not going to get excited. And then obviously if it's more than 4 millimeters, we do need to see them.
Okay, so the first port of call would be advised for an urgent ultrasound, and then based on that, decide about OPH or anything like that.
Yes.
Okay, thank you.
Anybody else? Okay. So now we've got a 51-year-old, 2-month history of postmenopausal bleeding. Periods have stopped a year ago. She's definitely menopausal. She's been using continuous combined HRT for 9 months, and a scan revealed an endometrial thickness of 3 millimeters. What are we going to do with this lady? Anyone want to hazard a guess?
Change to cyclical HRT.
Any other suggestions?
The last one, to choose hormone replacement.
So this is an SBA, isn't it? Single best answer. So, I mean, some of these things are definitely wrong. You're not going to bring her in straight away for inpatient hysteroscopy, for example. But yes, it would be between the second one or the last choice. So she is on a continuous combined. I know I haven't really gone into HRT, but sorry, I know it's a lot of writing, very busy. But someone on continuous combined HRT in the first 12 months, or if they're perimenopausal, they're more likely to get irregular bleeding. Therefore, the GP should consider changing to a cyclical HRT. So the second choice would be the first thing that you would do. So change to a cyclical HRT without any further investigation. And in these women then, after changing to a cyclical HRT, if they're still having ongoing bleeding for 6 months or more, then they need to be referred in. Or if with the last option you decide to stop it, but she's still bleeding beyond 6 weeks, then they need to have further investigation. So then she would need to have a scan and then a biopsy as well. But if obviously everything changed, if all the bleeding settles, then you know it was due to the HRT. Does that make sense?
Yeah.
Okay. Question. You're designing a retrospective review of cases of endometrial cancer and associated risk factors. Which one of these is associated increased risk?
Top one.
Yeah, perfect. So we've all learned now that smoking is protective, so we can take out 3 of those which have got smoking in. And remember, this is also, it's another SBA, so it could also be the third option, because increased age, obesity, oh sorry, the pill is protective, no, ignore me, I missed the pill. So say that the pill wasn't there, the first and third options would obviously be the right options, where you have to go for the single best answer. So yes, the first option would definitely be the best one. All those risk factors increase your risk. I don't actually think I told you this number. What's the incidence? Do we know how many cases there are per year in the UK? No, I don't think I told you this. Does anybody know anyway? No, the answer is 9,000. So there's 9,000 new cases per year. And I think, no, here we go. What percentage of these cancers are thought to be preventable?
34%.
Indeed. Perfect. And I think that's it. So as I've mentioned, you can do some more reading. So you could read the Green Top guideline on hyperplasia. I should have also put in here, there's a TOG article. Well, there's a couple of TOG articles. There was a recent one, I'm pretty sure January this year. And then there was one a few years previous to that. There's also a couple on hyperplasia, and there's also a strategy module as well, which goes into a lot more detail. It will be more for the part 2 exam. But if you want to have a read of that, then by all means, please do. So that was everything related to endometrial cancer that you need to know about. So let me stop this now.